Our speaker is Mafudia Suaray, MD, MPH, a graduate of New Jersey Medical School, also a graduate of the old UMDNJ School of Public Health, now the Rutgers School of Public Health, where she received the MPH. And she's a native of Sierra Leone. So it's going to tell you about some first-hand experiences in her country around this issue of the Ebola epidemics and give you some perspectives that you may not be aware of. And it's going to speak for about 40 minutes. We will leave some time for questions, and then you are free to take the food and go to the posters. So without further ado, Dr. Suaray, please come to the podium. Welcome.
Thank you, Dr. Escobar, for that introduction. I want to thank Dr. Escobar, Dr. Lin, the Office of Global Health, for giving me this opportunity to speak today. Special thank you to my husband for allowing me to cut our trip short so I can be here and be a part of this event. This is a great honor. The topic of Ebola is not just something that is of academic interest to me. It is a timely topic. It's something that's in the news. It's an ongoing issue, but it's also something that is personal to me. Like Dr. Escobar mentioned, I'm a native of Sierra Leone. I was born and raised there. I've been in the U.S. About 17, 18 years now, I think. But I go back home regularly, and I was in Sierra Leone at the start of the epidemic there. And what I saw and what I've learned and the things that are going on there continue to just keep me on my, on the edge and make me anxious and make me worried. And I think it's, something that we all should find challenging, and I hope to convey some of that here today. My husband and I still have family back in Sierra Leone. We have lost colleagues to this epidemic. We have lost family members to this epidemic. So this does hit close to home. I will be talking about some drugs and vaccines, but I have no financial interest in any of them. So my objectives for today, three main things. I want to construct a little bit more complex narrative about what's going on, what led to or contributed to this epidemic. Much of what is reported seems, to me, oversimplified. And the danger in oversimplifying the background to this is we tend to underestimate what is going on and underestimate the response. I will obviously talk a little bit about the epidemiology of the disease itself and the outbreak. And then I want to explore some of the challenges that lie ahead as the world tries to deal with this issue. Before I go into all of that, I just want to remind everyone that there is something everyone can do in this fight against Ebola. We all can do something. Okay, so you can volunteer, you can advocate, you can donate. Those are just three, basic categories of ways that you can be of help. So let's see again if my video works properly.
You're standing on the edge of a river. Okay. All of a sudden, a flailing, drowning child comes floating by. Without thinking, you dive in, grab the child, and swim to shore. Before you can recover, another child comes floating by. So you dive in and rescue her as well. Then another child drifts into sight, and another, and another. Eventually, hopefully, some wise person will ask, who keeps chucking these kids in the river? And they'll head upstream to find out. Every time we have to clean up an environmental disaster, every time a young person winds up in jail, every time people have to take medications to make up for the fact that they couldn't afford good food, We're suffering from the results of downstream thinking. Thinking upstream means making smarter decisions about what kind of country we want. What better goal could Canada have than creating the conditions for all people to enjoy true health and experience physical, mental, and social well-being? It's the best way to measure our success, and upstream thinking is the way we get there. Help us make the mainstream look upstream.
So that was a video that was obviously, made in Canada and was made relating to their health system. But the concept of upstream thinking, as opposed to downstream thinking, is one that's a global concept. So Ebola is just one of many threats to health and development that resource-poor countries face. Sierra Leone, Liberia, Guinea, all these countries that are now heavily afflicted by a huge one. It's one that is, that's got the attention of the rest of the world because of the threat to the rest of the world. But it is just one more disease. It's just one more epidemic. Millions of dollars in aid and decades of programs have been invested in countries, in resource-poor countries, to deal with the issue of global health disparities, poverty, disease. And yet still, we're dealing with epidemics every day. Yet still, we're dealing with malnutrition. We're dealing with low literacy rates and high mortality rates in a lot of countries. The root cause of all of this is probably the fact that we don't do enough upstream thinking. A lot of what we do is dealing with the issues as they come without really digging into what is leading up to these problems. And that's what the whole concept of upstream thinking is trying to bring about. So how does this relate to Ebola? So Ebola is just like one of those children that got chucked into the river. So let's talk a little bit about this particular child. Basics about Ebola: it belongs to a group of diseases known as viral hemorrhagic fevers. It is the most feared of the viral hemorrhagic fevers. It was initially discovered in 1976 in 2 concurrent outbreaks. It is considered a zoonotic virus in the sense that the natural host is thought to be a fruit bat. Humans had a terminal host for this disease. There are 5 known species of Ebola. The resting strain is not known to infect human beings. The Zaire strain has the highest mortality rates, and the current epidemic is a species that is similar to the Zaire strain. In an outbreak of Ebola, there are usually either one or few sources that are introduced from an animal host. So the predominant transmission in outbreaks is human-to-human transmission. The key thing to note here is that transmission only happens through direct contact with blood and body fluids of infected symptomatic people or infected animals, so the remains of an infected person or animal. There's also infections that can result when contaminated medical instruments and shops are used. Only symptomatic persons can transmit the disease. Nosocomial amplification of the disease happens a lot, especially when infection control practices are not followed. What we do know is that there has not been any airborne spread of this disease. So clinically, the incubation period is about 2 to 21 days. There's a constellation of symptoms that start from relatively vague symptoms to more GI symptoms. Hemorrhage, doesn't occur in a lot of cases, only in about 18% of cases. And very late manifestations of the disease are, confusion, delirium, renal failure. All those happen, in the end stages before death. How do we diagnose this disease? In outbreaks, there's a case definition, and the current case definition is increase in body temperature and this constellation of symptoms, in addition to a person having had a risk factor, an epidemiological risk of being in contact with someone who possibly had the disease or who is known to have the disease within 21 days before the onset of symptoms. This can be confirmed, by doing lab testing. And the mainstay of lab testing right now is PCR testing, which is highly sensitive and specific. Treatment for this disease: aggressive supportive care. That's basically what we have. There's a lot on the news about vaccines and drugs, but that's all in the works. Those are all experimental. The mainstay, what's been proven to work, is aggressive supportive care, especially early on in the course of the disease. The basic epidemiology of these outbreaks is that there's an index case, so one person gets sick. They're cared for by close family members. Those get sick. Someone dies from the disease. There's a funeral. People come in contact with the bodies. They get infected. At some point, some of the infected people will go seek medical care. And when you go seek medical care and you have an infectious disease and you go to a facility that has no infection control practices and don't know what they're looking at, you have amplified spread of the disease. That's about the time usually when the outbreak gets recognized and the alarm gets raised. And from then on, the main challenge is trying to break the chain of transmission. And you do that by identifying all your cases, isolating your infected people to protect your non-infected people, treat the cases that you have with supportive care. And if you do this right, your outbreak will end it will be declared over 42 days after the last person recovers or dies, and there have been no new cases. That's basically what happens in an Ebola outbreak. That's how it's been, and that's how it continues to happen. There have been 19 outbreaks of Ebola between 1976, when this was first discovered, to 2012. Which was the last outbreak before the current one. The largest outbreak before now was in 2000, and that was in Uganda with 425 cases and 224 deaths. The total number of Ebola deaths before 2014 is 1,300. And these are the countries, the regions of Africa where this disease outbreaks have occurred in the past 30 plus years. So what's different this year? Most people never heard about Ebola. They've heard a little bit about Ebola before 2014, and all of a sudden, in 2014, we have this huge epidemic. It's all over the news. Everyone is freaking out. What happened? Why? And the simple answer is it's complicated. It is. Why is it so complicated? So the countries that are involved in this outbreak are what make it complicated. So if we go back to that video about upstream thinking, we have to kind of go a little bit upstream. So before we talk about how it is, what the situation is right now, just want to go a little bit upstream and kind of look at what was going on around these countries, in these countries before this epidemic. Let's look at the narrative a little bit more closely. So this is Sierra Leone. This is my home country. And this is the basic profile of Sierra Leone. But beyond this profile, what you may or may not know about Sierra Leone is that it has a very complicated political and social history. Like many other countries in Africa, there's a history of colonization, there's a history of disparities, educational disparities, wealth disparities. There's a long history of poor governance, of endemic corruption. And also Sierra Leone and Liberia happened to have civil wars about the same time. In Sierra Leone, the war went on between 1991 and 2002. But even before the war happened in Sierra Leone, there's been a long history, decades of neglect of public infrastructure because of poor economic policies, poor governance, just general neglect of facilities. Things were really bad even before the war. And then the Civil War came on, and that lasted for about 11 years and just totally destroyed what was left of the infrastructure. There was a lot of brain drain. Those who can afford to leave the country, the most educated, the most affluent, left. After the war, post-Reconstruction efforts happened. A lot of efforts were aimed at programs that did not necessarily support building public infrastructure. So there might be programs around education, but the basic school infrastructures were not built. The health infrastructure was not built. And so this is the setting in which we have an epidemic. All over, throughout the years, throughout the decades of neglect, the people had lost interest and lost trust in the healthcare system. Most people self-diagnose their illnesses. You can buy medications on the street. You don't need a prescription, most people do not go to the hospital to seek medical care. They only go to the hospital as a last resort when they've exhausted all other, means of trying to get themselves healed. People trust their traditional healers more so than they trust, doctors. There are very few doctors, as you can see. With 2 doctors per 100,000 in the population, you have to travel quite a distance to find, one. And the ratio of nurses to patient is not that great either, 1 to 1,000. Literacy rates are low. Only about 3% of GDP is spent on education. And Sierra Leone falls, ranks 183rd out of 187 countries on the Human Developmental Index. Liberia was not a colony. It was a settlement that was created by freed African American slaves in the 1800s. Liberia also has a similar history to Sierra Leone of poor governance, endemic corruption, and civil war between 1989 and 2003 that left hundreds of thousands of people dead, infrastructure totally decimated. Like Sierra Leone, literacy rates are low. Little is spent on education. The healthcare, the resources for healthcare, medical resources are limited. 1 physician per 100,000 in the population. And they rank 175th out of 187 in the Human Developmental Index. Guinea, that you see here, has Sierra Leone and Liberia as neighbors. So the political instability extends into Guinea because they had to deal with refugees and rebels going in and out of this region. Very low literacy rates. Guinea has a long history of political instability itself. Again, you can see the same thing repeats itself. Small amount of money spent on education. Physician and nurse to population is very low, and Guinea ranks 179th out of 187. So in the middle of this came Ebola. So in December of 2013, that's when the index case for this outbreak happened. And it was in a village called Meliandu, where a 2-year-old became ill, was cared for by the family. So, family members got sick after the 2-year-old died, and they died. Funeral attendees got sick. Some people went to seek help in one of the health facilities, and then health workers also started getting sick. And this spread to neighboring villages. And eventually, the news hit the city of Conakry that there's an unusual occurrence of a disease going on. Doctors Without Borders happened to be in the region doing some work on malaria. And they heard about this, and they did some investigation. And they were very familiar with Ebola from previous outbreaks. So they helped raise the alarm about what was going on. So by March of 2014, the WHO reported officially that the country of Guinea had an outbreak of Ebola. So, but 3 months had gone by while they were trying to figure out what was going on. Towards the end of March, the CDC got involved, sending teams of experts to help assist in diagnosing this. By late March, Liberia started reporting cases, and by May, Sierra Leone started reporting cases. So when I learned in March about the outbreak in Guinea, one of my first responses was like, oh my God, this is going to happen in Sierra Leone and it's going to be a disaster. So one of the first things I did was call up the chief medical officer in Sierra Leone and say, hey, we have a problem coming our way. What are we doing about this? And everyone's like, oh, we think we have it under control. Yeah, we're going to educate people. But no one in this region had ever seen Ebola before. No one knew really what was heading their way. By mid-June, cases were being reported in Monrovia, which is the capital city in Liberia. And it just became like wildfire after that. And we all know that there have been cases exported to Nigeria, Mali, Senegal, and even cases in the United States and in Spain. So there's 3 countries that are involved, share very intimate boundaries. They have common tribes along their boundaries. They have very porous borders. A lot of travel for trade happens among these countries. So it is very easy for a disease like this to spread from one region to the next. In fact, it's not unusual for people to go from Sierra Leone to Liberia to seek medical treatment from, a famous, medicine man or something like that, and vice versa. So that, in fact, the first case in Sierra Leone, that's how it happened, was a lady who was very famous as a traditional healer who claimed that she could heal Ebola, started taking cases from Guinea and treating people from Guinea. She got infected, went back home to Sierra Leone, and started the epidemic right there. So what is going on with Ebola right now? So this is the latest status report. 15,935 cases with 5,689 deaths. Okay, so remember before 2014, there were only 1,300 deaths from Ebola total in almost 40 years. And right now, we already have 15,000 cases and about 6,000 deaths. In the past week, and this report was from November 26th, so this was just last week. In the past week alone, there were 600 cases reported in the 3 most affected countries. And this is a breakdown of what the cases and the deaths look like. The first bar is the number of cases, and the darker bar is the number of deaths. As you can see right now, Liberia still has the most number of cases reported, but actually their case rates are going down. And Sierra Leone, the cases are accelerating. And it's predicted by next week that Sierra Leone will have more cases than Liberia does. There were a few cases in the United States and a case in Spain. Nigeria and Senegal have been declared Ebola-free as of October, but they haven't had any cases in over 42 days. So this is a little bit hard to see, but in this column right there, it shows you the number of cases in the past 21 days. And you can see in Sierra Leone, I highlighted it, 1,339 cases in 21 days, compared to 319 in Liberia and 374 in Guinea. And this map here shows you the distribution of cases. The larger the dots, the more number of cases. And you can see there's a lot of yellow dots all over the place. Ebola has had a tremendous impact on communities. Whole communities have been affected. Households are dying. But the impact on healthcare workers has been really, really horrendous. This WHO started reporting the numbers of healthcare workers that have been affected. And these numbers only reflect doctors and nurses. It doesn't reflect other staff like your burial teams, your ancillary staff, your cleaners, and all the other people who get involved in taking care of a patient. These are only nurses and doctors. As you can see here, these numbers are not disaggregated based on, the death cases are not disaggregated. They only have number of reported cases and then total number of deaths. So the latest report, 592 healthcare workers, doctors and nurses infected with Ebola, and 340 of those have died. In Sierra Leone, I can tell you personally, there have been 9 physicians that have been infected, and 8 of them have died. The 8th person just died a couple of days ago, and I knew most of these people. So how did we get here? How did we not know, and how come we were not prepared for this? So one of the first organizations to raise the alarm was Doctors Without Borders, and that's what this cartoon depicts. But after the alarm was raised, what happened?
6 months into the worst Ebola epidemic in history, the world is losing the battle to contain it. Leaders are failing to come to grip with this transnational threat.
In a speech to the United Nations member states at the beginning of September, MSF's international president signalled the failure of the current strategy for combating Ebola. No organisation, and that includes MSF, is equipped to deal with the explosion in the number of cases, the dozens of infected health workers, and collapse of the affected countries' health systems.
Many of the member states represented here today have invested heavily in biological threat response. You have a political and humanitarian responsibility to immediately utilize these capabilities in Ebola-affected countries.
MSF teams in the field are utterly overwhelmed. They've treated over 1,000 confirmed Ebola cases in 5 treatment centres since the epidemic began. As soon as a facility opens, like here in Liberian capital Monrovia, beds fill up.
All areas, all districts of the city today have people dying and people getting sick every day. They are asking for help. They don't know how to respond to this, because if they call the hotline, nobody will come and pick them up because the system is completely overstretched. There are too many and the response is too weak.
MSF staff see coercive measures such as enforced quarantine only add to the panic and increase the risk of civil unrest. Equally counterproductive is cancelling international flights. Not only does it compromise humanitarian aid efforts, but it also weakens countries already in crisis. Punishing or isolating affected countries won't turn the tide of this unprecedented epidemic. The urgent need is for more treatment centres, more mobile laboratories and more skilled staff.
So this presentation was made in September, and the sad part of it is the rhetoric is still true. We still need more mobile labs, we still need more treatment centers, we still need more staff. The response is still slow. So this is kind of a brief overview of what the response has been. March, April, when the outbreak was officially declared, MSF sent teams to Guinea to help. WHO sent a team of experts. By June, not a whole lot was happening on the ground. The number of cases kept increasing. There was a call for massive deployment of medical staff and resources. And by August, I think this was about the time we hit the 1,000 cases mark. WHO declares that Ebola was a public health emergency of international concern. In September, the US and the UK deployed military troops and personnel. The UK sent some medical personnel to Ebola-affected countries. The US sent troops to Liberia and the UK sent to Sierra Leone. The UN formed a special mission to address this issue, and more countries started making pledges for financial and expert support. Very few countries were willing to send medical staff. Cuba has been, praised because they were the first countries that actually sent a contingency of medical staff. They sent 165 doctors and nurses to Sierra Leone to help deal with the epidemic. When November just ended and the results are still kind of mixed, in Guinea, the situation is thought to be probably stable. In Liberia, stable, maybe declining number of cases. In Sierra Leone, getting worse. More cases every day. There are a lot of treatment units that are still needed, a lot of treatment units that are understaffed, and a lot of the lab facilities have still not been built. So this is a map that shows you this is Ebola treatment centers, and this is in Guinea. So the green are centers that are actually open, and the yellow are centers that have been planned and still not open yet. So this whole area is Guinea. Yellow and red regions have higher number of cases. As you can see, there are only 2 facilities that are actually open to treat Ebola patients. All these other facilities have been planned, but they're still not open, and they still don't have staff when they do open that will be available to treat patients there. Not too different in Liberia, a little bit better. In Liberia, there are more facilities that have been opened, and this is probably thanks to the US response, bringing in a lot of personnel to build these centers. But there's 6 open treatment centers in Liberia. There's 17 that are planned and not open yet. In Sierra Leone, there are 8 centers open. There are 10 that are planned and not open. And just to give you, each treatment center has a capacity, or they built to be able to have 50 to 120 beds. And they're projected to need between 20 and 35 international trained medical staff to run each center, and about 200 to 300 national staff. Now, I just told you that we have, 2 doctors per 100,000 in the population, and, 1 nurse per 10,000. Where are you going to get that capacity to run the centers? So this is for labs that are needed. Because one of the biggest challenges, besides not having enough treatment centers, is not even being able to diagnose cases quickly enough. We know that with early treatment, with early diagnosis and early supportive care, even without fancy medications and no vaccine, with early supportive care, that's IV fluids, that treating pain, that treating other associated illnesses, survival rates can be improved. But first, you need to be able to find out who has Ebola and who does not, because Ebola could be like malaria, it could be TB, it could be anything in these countries. And these are all the yellow are labs that are planned, and the green are labs that are already open. And the distance between Sierra Leone, the whole region is affected. Same thing in Liberia. And you can see where the labs are. Specimens have to be sent from one region all the way there to get tested, and then wait for another day or 2 to get the results before you can decide what to do with that patient. And in the meantime, people die. If it was not Ebola and something else, they could be dead. Or the doctors might take a chance and see someone dying and decide to go ahead and treat them for what they think they have, and turns out the person had Ebola, and now the doctor's also infected. So, what have we been doing in the US? How have we responded to this whole issue of Ebola? The international response has been condemned as being slow. What about the local response, at least in the United States? There's been a whole lot of hysteria that happened, especially after the first case got diagnosed in the US. Problem is, there was not much media attention to Ebola before there was a case in the US, before they started treating Ebola patients in the US. And then after that, unfortunately, the media was who got to dictate how the Ebola rhetoric happened. And once that happens, you have a lot of hysteria going on. And I believe it was a Rutgers group, the Eagleton poll, that did a poll in October, of people in New Jersey and what they thought, was the potential for a huge Ebola outbreak in the U.S. And what was interesting was that the people who claimed to be following the news very closely were the ones that had the most misleading information and the most misconceptions about what this disease is and what this outbreak is, because of the way the media had covered the issue. So the CDC response in the beginning, there was a lot after the case in Texas. There was a lot of condemnation. But since then, the CDC has been very fluid and very adaptive in terms of their response and in putting out information and supporting hospitals and supporting facilities to make sure they have the information that they need to come up with an Ebola response plan. This hospital, among other hospitals, each have their own Ebola response plans, and it's located on the intranet for anyone who's curious to see what the hospital plans to do. Some states came up with quarantine laws that have been very controversial also. And these are just some of the things that have happened. The CDC has made changes to their guidelines regarding this. In the beginning, the recommendation was, wear a gown, wear gloves, wear a mask if you need it. And then after we had the 2 nurses got infected, CDC really looked at their guidelines and looked at what was happening with this disease and how hospitals, were responding, and came up with, more clear guidelines as to how they wanted people to, the staff to be protected. And another things that they did was come up with more specific guidelines on how to determine who is actually at risk for having Ebola, especially in light of the enhanced screening that were being done at the airport. What I've highlighted is, New Jersey specifically has additional, laws regarding quarantine, where people that fall into this high and some risk category will fall under the state quarantine laws. So what CDC does recommend is that there should be active monitoring for people who have some risk in terms of they've had some exposure to someone with Ebola. High risk meaning they were not protected at the time of the exposure, and some risk meaning they wore proper protective gear, but they were involved directly in the care of someone who had Ebola. And no risk meaning you're just your everyday person in New Jersey or in the US who doesn't even know anyone who has Ebola. Don't worry about it. So what lies ahead? Looking back, there's a lot that has happened. The situation is still there. A lot of people are still dying. The infection rates are still high. What do we have to look forward to? A lot of kids have been orphaned. This, talk of treatments and vaccines. Death rates are still going up, and tough decisions still need to be made. One of the things that is not being talked about is what I call the epidemic within the epidemic. So the CDC had made a projection that by January, which is just about a month, there'll be 550 to 1.4 million cases if drastic measures are not taken. Now, right now we're in the first week in December, and I cannot really say that drastic measures have been taken. So we don't know where we're going to end up falling with this number based on how things are going. There's reason to be hopeful, but there's also a lot of reason to be concerned, considering the current trajectory. On the health front, the increasing number of deaths from other neglected diseases. These are not even being documented. Okay, I have a cousin that died a couple of months ago. She was diabetic in Sierra Leone. There was no insulin anywhere in the country because all the efforts have been on Ebola. Government hasn't been, paying attention to stockpiling other essential medications. She ran out of insulin and she died from complications of diabetes. Maternal mortality rates every day, I hear horror stories about pregnant women dying, bleeding to death. Because they come to, a facility, they're bleeding. You don't know if they're bleeding because they have Ebola or they're bleeding because they're having a complication of pregnancy. And a lot of times they die because everyone is scared to touch them. Schools have been interrupted. There haven't been any schools since school closed for the summer. They haven't reopened, and we don't know when they're going to reopen. Teen pregnancy rates are going up because the kids have nothing else to do. Healthcare workers are dying or leaving the country. Those who can afford to leave are leaving the country, and others are being infected and dying. The UNICEF estimates about 7,000 children have been orphaned so far by this virus. So among the three most affected countries, we have over 5 million kids who are out of school. And we don't know if they will be able to go back to school anytime, in the next few months. Dropout rate continue to increase, which means illiteracy rates are going to continue to increase in countries with already high illiteracy rates. With illiteracy comes poverty. With poverty comes more diseases related to poverty, and the cycle continues. There's some hope in the horizon. There's talk of new treatments, convalescent serum, ZMapp, among a whole host of others. Some of these treatments are in phase 1 clinical trials right now, and there's hope that they will proceed to the next phase soon. Vaccines, they've been in the news recently. I believe it's this first vaccine that they've shown some promising results in the first set of trials, and they expected to start testing them in the region in the next months and scaling up production of these vaccines. But all of these are not going to really help end this current epidemic. The mainstay still is going to be treating your cases that you have, isolating people, providing good supportive care, which we're still not doing. We still don't have enough staff to do that. It's going to take months to get the adequate data for all these vaccines and this treatment to find out which one works. So they'll probably be more helpful in the next outbreak, but not so much in this outbreak. Even the issue of rapid tests, we're still waiting days to get results from tests. There's talk of developing a rapid screening test that there's at least one candidate screening test is being tested right now. There are lots of ethical challenges that lie ahead, especially as we talk about vaccines and new treatments. Trying to balance the goals of research with the ethical issues, and these are just a few issues. Currently, there's no standard of care for treating Ebola. We all know that the people who got Ebola treatment in the US predominantly did well, except for 2 people who died, and that could be easily traced back to delay in getting much needed treatment. But for the Americans that got infected and the other people who got infected and got very good ICU level care in this country, they survived. The survival rates in this outbreak right now is anywhere from 60 to 70%, and in every treatment center, what is available is different. In some places, all you get is oral rehydration salts. Now, people losing liters and liters of fluids every day, and if they're not able to hydrate by drinking, they're dead. They can't even get IV fluids. Doing research in these settings with high illiteracy rates, how informed is informed consent going to be? People are already scared, people are panicked, they're not very literate. How are you going to make sure that they understand consent? What is the best research study design to use? There's been a lot of talk about, is it ethical to use randomized controlled trials, but there's an emergency going on, we need to get results quickly, but we also need to make sure that the results that we get are meaningful. There's going to be limited resources. No matter how many thousands of doses of vaccines and treatments, it's not going to be enough for everyone in the population. How do you allocate those resources? Who gets to decide who gets this new vaccine or this new treatment? How do we protect the rights of research subjects in these areas? How do we balance individuals' rights against public interest? Judge Bernard Shaw said that the worst sin toward our fellow creatures is not to hate them, but to be indifferent to them. And that's the essence of inhumanity. So there is something that we all can do. Again, as institutions, as individuals, we can volunteer time, we can volunteer expertise, both locally and internationally. Not everyone can, get a ticket and go to Africa right now and help, fight Ebola. But there, all those organizations that are sending volunteers overseas also need volunteers here to help screen and get things ready. They need logistical experts. There are a lot of advocacy issues around this crisis. And there's a lot of needs. There's a lot of medical supplies, essential medications, just funds, things that individuals can easily do, institutions can do also. So stuff like what Rutgers and Jim Simon and others have done, donating supplies, but also partnering with health facilities, adopt a clinic, adopt a hospital, and help them get the supplies that they need, help them get the expertise that they need. So Ebola is a preventable disease. This current epidemic is the largest that has ever been known in history, and there's complex global factors that have contributed to that. But unless specific actions directed towards the upstream causes of the epidemic are addressed, this particular disease and many others will remain threats to global health. Experimental treatments for Ebola pose several ethical challenges with grave implications that we cannot ignore. And there's something everyone can do to help in the fight against Ebola. So, this is where I'm going to leave it, and I ask for any questions.
Thank you, Dr. Suaray, for a wonderful, marvelous presentation.